This is Focus on Your Health on the KJazz Radio Network. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week we're talking emergency medicine. My guest is Theresa Ojala. She's the Director of Emergency Services at KRMC. Hi, Theresa. Welcome.
Hi. Thank you. Thank you. I'm happy to be here.
Yeah, I'm glad to have you. I wonder about the ER a lot when I go by. Emergency medicine is a different species of medicine altogether.
It is. Absolutely.
I imagine it's a special kind of provider who is called to do this job.
It is, absolutely. And when we hire people, we're looking for those who have fire in their belly. That's my key, is if you have fire in your belly for this job, that's already set you up for a better interview than the average person.
I'm thinking for a lot of physicians, I know there are long hours. I know that there are usually staffing problems. But typically, you can go home. You can call it a day. In the ER, you have crazy shift work, and you probably don't go home until the work is done. And
in many cases, that's
right?
true, yeah. If you've got a critical patient, you're certainly not going to hand off in the middle of that to the next guy coming in just because you're looking at the clock and you're like, I'm done here.
Yeah.
Right, whether it's the physicians or the nurses.
How long have you been director here?
I've been the director here just short of 9 months.
Okay.
Next week will be 9 months.
How's that going?
It's going well. I love to tell the story of how I got here.
Please do. I'd love to hear it.
My husband and I were, I'm from Wisconsin.
Uh-huh.
I've spent 54 years of my life there. And we were deciding where to go vacationing this summer. And we were interested in the Southwest, started researching online.
Yeah.
And the more we looked, he said, we should just move there. And he said, well, start looking. And I didn't, but the phone rang, and it was a recruiter for Kingman, and I am now sitting across from you.
Here you are.
Yes.
9 months here, and you said it's going well,
Mm-hmm.
but if it had been really, really difficult, would you tell me that?
I would.
Yeah.
Mm-hmm.
Yeah.
I have 21 years in the business. Mm-hmm. I started as a EMT out in the field for 10 years, and then I was a frontline staff nurse in the emergency department for 10 years, and I've now been in management for 11 years. So I know it pretty much inside and out.
Yeah.
And really enjoy helping people grow to be the best that they can be in their specialty.
Now, in those beginning years when you were in the field and working you're an RN, so
I
you're
am.
working in emergency rooms, did you ever picture yourself going into the administrative side?
I did not.
Yeah.
And the interesting story there is that I was working for a small organization where I was also the parish nurse coordinator. That's a long story that I won't get into.
Okay.
But I was off campus doing a seminar, and I got a phone call that our nursing director had left effective immediately. And the staff members were handed a list of characteristics and asked to find somebody within...
Who fits the bill?
Who fits the bill?
Yeah.
To find somebody who, look at that list and who do you see? And I came in the next Monday and was handed the list of signatures naming me unanimously as their new team leader, and did not see that coming.
This is kind of like that Three Stooges scene where they ask for volunteers and everybody steps backward, and whoever's left on the line gets the job, right?
Yeah, so it was really an honor to be chosen by the people unanimously to lead them, and that was the beginning, and the shoe has fit ever since.
So let's talk about the ER here at KRMC and some of the facts and figures, some of the unique challenges that you face. It's a long way to go to get to another emergency department, is that right?
It is a long way to go.
Yeah, we're out here on the frontier.
We are. As I was driving out here after I interviewed, I was looking around and I said to my husband, who picks these people up out here if they have accidents and whatnot? And I learned pretty quickly that because we have a 265 square mile catchment area for patients, that we pick them up. We have a limited space. We have 37 what I call care spaces, and I say that because we have few doors and more curtains than doors.
Right.
And so we have limited space to take care of patients, including hall and desk beds. We are a level 4 trauma center. I think we have capacity to grow to a level 3 and would hope to do that in my tenure here. We have 3 major highways that run through here. Mm-hmm. So we get every bit of trauma that that happens out there.
Can you tell me about the difference between level 4 and level 3?
Well, level 4 is a state designated level, and that just means that you have basic equipment and staff to be able to take care of the trauma patient.
Right.
The top level of trauma center is a level 1, followed by a 2, 3. So we are 4, would like to go to a 3. Mm-hmm. And to be a 3 would require significant amount of surgical involvement, including call. So I know that we don't have a real large pool to draw from, so we're doing the best we can to make a really strong level 4, take care of the patients the best we can, keep the patients that we can, and then mostly the multi-system trauma we'll send to Las Vegas because it's closer, maybe to Phoenix, depending on what the patient needs.
Right. And that's typically by helicopter because that's an emergency kind of.
Yes.
There's no time to waste.
Right.
Yeah.
We are on track to see about 53,000 patients in this department this year.
Oh my God.
We admit 21%, which is pretty average across the nation.
50. I'm sorry to interrupt. I'm just pausing to consider that. How many is that per day?
So I'm glad you asked, because that's, I think, even more telling or more surprising to people is on average, we see 150 patients every day.
That's incredible. I'm sure no one, I'm sure very few people realize that.
Since I've been here, I think the lowest number that I've appreciated was on Easter Sunday. I think we saw 119.
Wow.
Our high number is 189. And we've seen that since I've been here. Our winter period, which is generally the busiest season, is December through April. And our busiest day of the week is Monday, followed by Friday.
Can you parse any meaning out of any of that?
Absolutely not.
No, okay.
No. It's the highs and lows, the volume surges, and there is a standard bell curve for every emergency department that is low during the morning hours, and then it starts to ramp up maybe 9, 10, 11 in the morning, and then you peak late afternoon, early evening, and then maybe about 1 in the morning you start to kind of are able to step back, take a breath, get recalibrated, and look forward to the next day.
With the understanding that at any given moment, someone who's had a run-in with a nail gun could walk through the door.
Right, absolutely.
So I know that people in emergency services tend to be a superstitious lot, and they tend to talk about full moons, and they tend to talk about days of the week and holidays. And
I've been assured that the research doesn't support that.
Okay.
And I can tell you, though, 21 years in the business, I still believe it.
Anecdotally,
I still believe it. As it relates to babies being born, as it relates to people's mental stability, kind of getting a little out of control. So I do subscribe to that.
Now, in addition to the physicians and nurses you have working here, this is also a teaching facility.
Yes, it is. And I think that's great. We have a resident teaching program. So we have physicians who work alongside our attending physicians, and they spend 4 years in the emergency department, and they also do some stints with some of the specialists. They might spend some time in surgery or over an OB, but primarily they're here to be trained as ED residents. We also have a nurse residency program that just started, which allows new graduates to identify a department that they would like to specialize in, whether it's med-surg or our critical care area or the emergency department. And then they spend 16 weeks really getting well-oriented and becoming well-oiled machines so that by the time they're through with the residency program, they hit the floor running and have a comfort level and, just fit right in. In addition to that, we have RN students from Mojave County Community College and NAU, and we have plenty of emergency medical services students that come through here as well.
And with all those patients coming in, I'm sure you have lots of work for all the
we do.
The trainees.
There is never a dull moment, and there is always something to do.
In all your years of working in this field, I imagine you've seen a lot of changes come along.
I have.
Yeah. And I have a little note here about patient expectations and also the cost of medical care. Tell me a little bit about that.
Well, we strive to have a world-class emergency department. And you might not think that that's manageable in Kingman, Arizona, or in a rural hospital setting, but it is, because we align with our vision, which is to provide the region's best clinical care and patient services in an environment that fosters respect for others and pride in performance. We align with our values of compassion and commitment. We embrace and employ evidence-based practice and leadership. And we hire the right physicians and nursing staff. It's difficult to draw nursing staff and physicians here on some level. However, we still have the capacity to be particular. We want the right people in the door. We want the people who can align with the vision and values almost at a cellular level, so that that's not something that you have to train. Right. The clinical skills and the leadership skills and the management skills, those things can be taught. Right. But I'm really happy when they come through the door and they just impress me right off with getting this at a level that...
You can spot that right away.
Yes, yeah. and that fire in the belly that I talked about before.
Sure. Yeah.
And then most importantly is the feedback from the patients, the community members who do visit us. We want that feedback to know how we can do better, because even though we have all of these other things, the vision, the values, the evidence-based practices, we still have opportunity, and I know that. And so always want the feedback to be able to make things right.
It's break time on Focus on Your Health. We'll be back in a moment for more with Theresa Ojala. This is the KJazz Radio Network. And welcome back to Focus on Your Health, here on the KJazz Radio Network. This week my guest is Theresa Ojala. She's the Director of Emergency Services at KRMC.
When we talk about evidence-based practice, what that really means is it's research-based, that it has been found to be obviously the best way to do something.
Right.
An example of that is the use of AIDIT, which is an acronym that stands for Acknowledgement, Introduce, Duration, Explanation, and Thank You. So it's a practice that if we standardize how we do that with every patient every time, then we're going to be sure that they're kept informed, that they're cared about as an individual, and then we've got their best interest in mind. So we're trying to hardwire that practice, and that's just one example of what I consider evidence-based practice.
So when you talk about the acknowledgement, I mean, a lot of people, they understand they're going to, if they have to go to the ER, there may be some serious cases in line in front of them. And that's just saying, it's just keeping people informed and not letting them feel that they're being ignored out there in the waiting area. Because
there are many times these days where all of the care spaces in the back are full and our waiting room fills up. And it's less and less uncommon for us to have 20 to 30 people who are waiting.
Yeah.
We try to stay on top of that and make sure that somebody is rounding on the patients to tell them what's happening, where we're at. We can't give specific time frame, but I might, as the nurse sitting out front, know that the last person who had been waiting, who finally got pulled back, maybe it was 2 hours. So I can give you a time frame, but I can't give you specifics.
And I imagine that also helps you to stay aware of, because it's a dynamic situation in the waiting room,
Absolutely.
Right? So if someone's condition changes a bit, it helps you to be aware of that.
And I think because more people are using the emergency department for primary care.
Yes.
Not out of anything other than they can't get in to see their primary care provider in a timely manner. They know that, we're here for them. So we do have the full spectrum of somebody who is pulseless, non-breathing, to somebody who has a sore throat and just wants it taken care of.
Okay, but I got to say, I would probably want to scream at somebody who comes to the ER for a sore throat or a cold or something like that. And maybe maybe I'm not the right fit for this job.
Well, it's not to say that those thoughts don't go through the staff's head at times.
Yeah.
However, I don't care what emergency department you go to across the nation. You'll have that full spectrum.
Mm-hmm.
And we break that down by emergency severity index. So there are certain criteria for you to be a level 1. Primarily, you're not breathing, you don't have a pulse.
Yeah.
Level 2 is something more aligned with it's either life or limb threatening. An ESI level 3 is probably the toughest because you can take that and split it again 3 times as far as what resources somebody might need. Abdominal pain is a perfect ESI level 3 because you might just be diagnosed with gastritis and be sent out with a prescription, or you might need a full blood workup, x-rays, because you might have a AAA, which is, your aneurysm, abdominal aortic aneurysm is in trouble.
Right.
And then the 4s and 5s are fewer resources, less urgent. Mm-hmm. Maybe you're here with that sore throat and you don't appear to be in any distress. So that would be the lowest level. So that's been forever, I will tell you that. What I've seen in 20-some years, though, is because of the lack of primary care, people just need to reach out somewhere.
Right.
And urgent care is perfect for those level 4s and 5s, yet they're very busy as well.
You have mentioned that surveys are important and you need to know what patients are thinking and how their experience with the ER goes. And certainly you want to provide great care, but you also have to deal with people's perceptions.
Absolutely. Absolutely. And perception is reality. Because of the busyness of the department and the numbers of patients, many times it seems like you've been forgotten, you don't feel cared about, or you don't understand the why. And I go back to why it's important that we keep you informed. And so I want the community to know that if they visit the emergency department and they are not being kept informed, we're not managing their pain, we're not treating them respectfully, we need them to advocate for themselves and to remind us what our promise is. And it is to keep you informed the best we can, to try to manage your pain the best we can, given certain parameters, of course.
Yeah.
And always treating you respectfully. Yet when it gets busy and people get on edge, many times we even have that discussion within ourselves. Just because somebody lashes out at you, it's not, or doesn't treat you respectfully, sometimes it's just the heat of the moment and it's not personal.
You're there.
But we do care or we wouldn't be in the business.
Of course.
And the more we understand each other, the better we can support each other in our efforts to create what I think is a mutually respectful and positive relationship, because we're in the people business, we are in the caring business. We want you to feel that here at KRMC. Want you to know that we are a fabulous resource. However, we are the most expensive, as you mentioned.
Yeah.
And it is limited by the care space and by the number of patients that are, arriving for care at the same time. And we are the only place for a true emergency. So when we're trying to take care of true emergencies and sore throats at the same time, I hope that people can understand, where we're trying to balance that the best that we can. We're not set up like our primary care physician office. The emergency department was designed for emergencies. Primary care physician clinics are designed for chronic conditions, identifying what some of the tests are that need to be done to find out what's going on. We don't have all of that at our fingertips. We have radiology, we have lab, we have a lot, but we don't have it all. Right. And an emergency department physician is an episodic physician. He doesn't have a practice where he has patients that he or she sees after they've taken care of them in the emergency department.
Right.
So we're built for immediate life-threatening emergencies and not to diagnose or manage chronic conditions. We implemented a nurse first process back in October.
Tell me about that.
Previous to having nurse first in place, we had our wonderful patient admitting personnel at the front desk, and they would do some intake of information and then send the patient to the triage nurse. With the nurse first process in place, we have medically trained eyes at the front desk 24 hours, 7 days a week, because we understand how important it is. And in light of people having to wait in the waiting room, it's good to have medically trained eyes as people's conditions may change.
Have you already seen the benefits of having nurse first?
Yes, yes, definitely have.
Yeah.
Some of the other best practices that we're using include a process called pull to full, which means as long as we have care spaces open, we should be bringing patients straight back. We shouldn't be having patients go to another queue with a triage nurse. They should be able to be brought right to the bed and get all of the information gathering done there. Mm-hmm. We have whiteboards in the rooms, and any of you who've been here will have been apprised of those. The whiteboards are the way to visually keep you informed. It has the care team members. There's an area that identifies what labs and testing you're having done, and gives you kind of a time frame of how long those things might take before they're finished. And it's a place for us to have a visual on your pain. If you come in with, say you have a pain that's an 8 out of 10, we would identify that on the board. We would ask you what is a tolerable level, because we're not always going to be able to take the pain away, and then work toward that goal with you. And then just continuous work on our approach to patient flow. We know we have some opportunity. What we don't have is a floor plan that we can expand. We have what we have. The square footage of the emergency department is what we have. So knowing our limitations on staffing, knowing our limitations on the physical plant, we have to work smarter to figure out what's the best flow for our patients. And we're constantly paying attention to that and trying to do that better.
So it sounds like you've made some changes, or some changes have happened maybe as a team since you've come on board. And I wonder what is ahead, if you have plans you can share.
That's a really good question. One I ask myself almost every day.
Yeah.
We're working as a leadership team within the department, and we will certainly bring other stakeholders to the table as we need to work together to create the best environment and the best patient flow that we can. And just really ask for the community's patience and understanding as we try to do that. Some of the processes are systems issues. When we can't get patients moved upstairs to the floor for a whole host of reasons, we may have to hold patients longer than we like to in the emergency department, but that's the nature of the beast. And so when we have situations like that, we make sure that everybody who needs to know, whether it's directors, managers, physicians, we try to get everybody on board with getting people moved as quickly as possible. So a continued vision toward being, as I've already referenced, a world-class emergency department.
Well, Theresa, it's a challenging job, and I don't know if it's one I would want, but I'm glad you're here doing it for us.
And I'm glad I'm here as well. Thank you.
That's Theresa Ojala, Director of Emergency Services at Kingman Regional Medical Center. You can email her at tojala@azkrmc.com. That's TOJALA@azkrmc.com. And that's the show. We are out of time. I'm TG LaFredo. Thank you for listening, and please join me again next Saturday at 11:30 a.m. for another edition of Focus on Your Health, right here on the KJazz Radio Network.